Dear ladies and gentlemen, welcome to our workshop about the management of urinary tract infection in the era of antimicrobial resistance. I would like to start with a global perspective on urinary tract infections. And this was a study performed and highly published in Lancet. It was about the analysis of the global burden of disease study. And data from this study were taken by another group, and they have calculated that already in the year 2019, we have 405 million cases of urinary tract infections. We have about 230,000 deaths related to urinary tract infections. And the risk that you can die because of urinary tract infections has grown as well in the decade from 1990 to 2019. So we have to say that with urinary tract infection, we have a problem. And now I would like to come to our agenda today. So I will start with a welcome and opening remarks. Then I will speak about the management of urinary tract infection in times of increasing antimicrobial resistance. Then I will hand over to Katrin Bausch from Basel, and finally to Mrs. Pothoven from Den Haag. And around 3 o'clock we will have a round table and nice questions answer discussion. And what would be great, you don't have to be afraid, don't fear us. We would like to have an interactive discussion with you. So please, if you have questions or remarks, please do so and let us know. So, coming to my first talk. Introduction, that's me. My name is Gernot Bonkert. I'm 52 years old. I'm born in Germany, married, one daughter, one wife, one house, one dog. And my parents are still alive, and I'm a board-certified urologist with a deep interest in infectious disease. I live and work in Basel, Switzerland, and Basel is a nice city. It's the third most populous city in Basel, which is about 175,000 inhabitants, and it's well known as a cultural capital of Switzerland because we have many, many museums. This is my private practice. This is my team. Quite interesting during these times that we have so many different nations and we are all getting quite good along to each other to work for our patients. We are offering a broad spectrum of urology, and these are my affiliations. Beside my work in private practice, I have some affiliation with the university or with the ESIU or with the EAU, the European Association of Urology. And since 2015, I'm the chairman of the guidelines on urological infections. And it's so nice to see that these guidelines are used worldwide. They are used by more than 74 national societies and scientific organizations, including all 27 EU member states. But look, what is the difference? I can see the whole room is full. Very nice. People are standing here. We have possibilities if you would like to sit down. And this was the same 15 years ago during urological congresses. No one was interested in infectious disease. And when I started my scientific career dealing with infectious diseases, it was said, no, a real urologist are not dealing with infectious diseases. You have to do for prostate cancer, bladder cancer, and so on. But nowadays, you can see that we have an increasing interest in infectious diseases. And it was among top 3, but this has changed as well. You know, we have 16 guideline panels. And the number 1 of the guidelines, most downloaded, is prostate cancer. But we now made it to the second place. So the infectious disease guideline is the second most downloaded guideline of all European guidelines. And in the non-oncological field, we are number 1. And the question is, why is this so? Why? What do you think? Why is it? It's because it's interesting, because we are dealing with a lot of diseases relevant not only for regulars but as well for specialists. So we are dealing with sepsis, urostritis, prostatitis, complicated, uncomplicated urinary tract infections, and so on. So we have a very broad spectrum. But on the other hand, we are facing more and more the problem of antimicrobial resistance. And we have already received a warning in 1945. In this year, Fleming, Jane, and Flora received the Nobel Prize for the development and the factoring of penicillin. And it was said already that the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with a penicillin-resistant organism. And in 1969, this US general said that it's time to close the book on infectious diseases and declare the war against pestilence won. And nowadays, we know that this is not true. This is an antibiogram taken from a colleague of mine from India. And you see there are many antibiotics tested against a bacteria found in a urine culture from a patient. And you see we have really a problem. And is it just a problem to have cultures where you can see that it's not working, no antibiotic is working anymore? Then let's take a look to the mortality projection. This is an O'Neill report already published almost 10 years ago, and it was calculated that by the year 2050, 10 million people worldwide will die because of antimicrobial resistance. This is meaning that in 2050, more people will die because of antimicrobial resistance than of cancer. And of course, it's more a problem for Asia and Africa than in Europe, but it's still a problem. And the young among us, you can perhaps say, oh, 2050. You know, if you're getting older and older, then time is running. But perhaps the younger of you, you will say, okay, 20 years still to go or more. But what is the situation today? Today, or in 2019 already, we had 5 million deaths because related to antimicrobial resistance. And if you take a little bit a deeper look into the studies, then you see that among the first 6 bacteria, there are our bacteria, the urological bacteria, E. coli, Klebsiella pneumonia, Acinetobacter baumannii, and so on. So these are our bacteria. For me, always important just to set a little bit the scene, because later we will discuss the problem of recurrent urinary tract infection. It's always important that we know what we are speaking about. And there are different classifications of UTIs. For me, most important is that we can differentiate between uncomplicated and complicated UTIs. And this figure should explain it a little bit more. For example, if a patient is coming into your office, or you see a patient and the patient is describing the typical symptoms of an UTI, then you not immediately know whether it's an uncomplicated UTI or a complicated UTI. Uncomplicated, just keep it in mind, are young premenopausal women with no pregnancy and with no abnormalities in their urinary or urogenital tract. All, by definition, all others are complicated. And complicated is meaning that you have a higher risk to develop a complicated cause of the disease. Important, again, asymptomatic bacteria. It's meaning you are going to your GP for a routine checkup, you have no symptoms, and then a urine culture is taken, and then you find that there are bacteria in the urine culture. And then your GP is calling you and is saying, hey, you need treatment, you have bacteria in the urine. And this is wrong. We have treated it in the 70s, 80s, and 90s for sure, because it was said that the urinary tract is clean or sterile. Nowadays, we know that we have bacteria until a certain amount in our urine, and if you have bacteria in the urine and you have no symptoms, then these bacteria might even play a protective role in your tract. Just a bladder infection, uncomplicated cystitis, most probably you know if you had cystitis in the past that it's not just an uncomplicated infection, so you have symptoms, you have restricted activity, perhaps you were on sick leave or you needed even bed rest. So it's much more than a simple infection. And if you have more than 2 infections or more in 6 months or more than 3 in a year, then you are suffering from recurrent infections. The problem with recurrent infections is that many women are suffering from recurrent infections, and that could be up to 10 or 15 episodes per year. Coming to the uncomplicated cystitis again, so uncomplicated cystitis affects women only per definition. And then is the question why women are being so more often likely to have a UTI than men of the same age. Then it's discussed, it's because of anatomical differences, it's a longer urethra in males, or the shorter distance between the anus and the uterine opening in females. But nowadays we are discussing why then boys or older men have similar rates of urinary tract infection compared to females, because we assume that the length of the urethra is not shrinking. And so it's a place we have to discuss the influence of sex hormones. This is highly interesting nowadays for us. Here you can see the sex differences in UTI susceptibility, and you can see that estrogens in women and testosterone might play a role. Coming to the diagnosis, if you have a first episode of a UTI, then the symptoms are enough. Of course, you have to take a medical history, a short physical examination. Point of care testing is what could be heavily discussed because the dipstick testing has many drawbacks, so I would recommend just to diagnose according to symptoms. We recommend not to take a urine culture if a patient is coming for the first time, but if the patient is coming back in a few weeks with another episode, then for sure we should take a urine culture. This man has published a landmark paper in urology in 1956 case, and he said that asymptomatic bacteria might be differentiated from patients with a pyelonephritis because of the bacterial count, 10 to the power of 5. And then this count were taken by laboratories worldwide, and everyone was saying, if you have a urinary tract infection, then you need to have a bacterial count of 10 to the power of 5. And if you had a bacterial count of 10 to the power of 3, then the doctor said you have no infection. This is definitely not right, so forget please about this number. Coming to the pathogens, E. coli, number 1, then we have Klebsiella, Enterococci, and so on. And regarding the area, the place where you live, you have different other pathogens. Coming to the therapy, if you have an episode of uncomplicated cystitis, you have to know that you have options. You can go for antibiotic-sparing strategies. This is meaning that you can work, for example, with a painkiller or with phytotherapeutica, or you have antibiotic strategies. Shortly to the analgesics and the phytotherapy, this is a recent published meta-analysis about this topic, and you can see that it's possible that you can spare antibiotics. Overall, the use of antibiotics in this study was reduced by 60 to 70%, but if you counsel your patients, you have to inform them that they have a risk about 5%, that the patient will develop an upper urinary tract infection, a pyelonephritis, and they have probably a longer course of the disease, meaning longer symptoms. Coming to the antibiotics, and there we have our guideline, what are we recommending. You can see that first line option is a phosphomycin. Then we have different formulation of nitrofurantoin, and in the Scandinavian region we have another antibiotic, and we have alternatives. But one group is completely missing. One group is missing. Do you know which group of antibiotics? Any idea? It's still prescribed, but it was used heavily for urinary tract infections. It was used for antimicrobial prophylaxis. It is still allowed to use in animal farming. It was given in highly dosages during the Desert Storm and Desert Shield operation because the soldiers should be protected against anthrax. And nowadays, these drugs are considered to be a mitochondrial killing machine. And these drugs were banned by the European Commission in 2019. And I'm speaking about the so-called fluoroquinolones. And nowadays, there are terms like I am floxed, I have collateral damages from fluoroquinolone antibiotics. And there are lawyers around the world and suing us if we prescribing these drugs. So it's very important that we are not prescribing fluoroquinolones in the setting of uncomplicated UTI. A fluoroquinolone is a drug ending of oxazine, ciprofloxacin, levofloxacin. They are not allowed in European countries, in EU countries, for the treatment of uncomplicated cystitis, not because of antimicrobial resistance, but because of the side effects. The patients could suffer from long-lasting side effects like neurological disorders, induction of diabetes, and so on, and therefore it's not allowed to give these drugs anymore. Then it's a question, which antibiotics should we give? And this is important that we at least know a little bit about our local resistance data. This is the ARES study published already in 28, and you can see urine cultures from patients with an uncomplicated UTI, and you can see, for example, that E. coli 76%, and then there's a huge gap followed by Klebsiella pneumonia 3.54%. Then we have data from our antibiotics, and you can see that the fosfomycin and the nitrofurantoin, they are working quite well, almost 100% working. And in comparison, the cotrimoxazole is working not so well. That's why we are not recommending cotrimoxazole as a first-line treatment in uncomplicated UTI. But now take a look in a recent study published in India. And these are data taken from whole India, and you can see that E. coli is still number one, but you have, for example, Klebsiella pneumonia with 77% number two. It's much higher than in European countries. And then you have to consider regarding the antimicrobials you can use that you have a very high resistance rate of, or in Klebsiella pneumonia against the nitrofurantoin. So this is always important that you keep in mind what or where do you live, have a good contact to your microbiologist, and you need the susceptibility patterns of your bacteria. Coming to the prevention of urinary tract infections, and you see you have many, many options. So you have antibiotic sparing strategies, you have their behavioral changes, anti-adhesive treatments, antiseptics, and so on. Of course, you can go for an antibiotic or antimicrobial prophylaxis. You can give this prophylaxis continuously or postcoital, and then we have a few experimental strategies. And with this, I would like to hand over to my colleague Katrin Bausch from Basel, because now I'm keen to hear from her what of these different means of treatments are the best to lower our rate of recurrent urinary tract infection. So thank you very much, and Katrin, your stage.
Hello, everybody. It's nice to see so many people here. So, as Gernot already mentioned, I would like to talk about how to prevent urinary tract infections in 2023 based on the new guidelines that were just published. I'm also from Basel, as Gernot already said, and I'm working in a hospital there, and I've also been to Paris for a while, working on how to prevent finding measures to prevent urinary tract infections or to reduce the use of antibiotics. And I'm bringing that back to the clinics now, also conducting many trials on how to prevent urinary tract infections. I would briefly like to say something a little bit about the background and diagnosis, and then also jump into the prophylactic measures. So for the background, we are still dealing, as Gernot said, with E. coli, which is more than 76% of in the uncomplicated cystitis. But when it comes to complicated cystitis, this blue part becomes much, much smaller. There are many, many more bacteria becoming important, and in a complicated cystitis, also antimicrobial resistance. So what is a recurrent UTI? There's a definition saying that it's 2 infections in 6 months, or it's over a year, it's more than 3 infections. But let's look at reality. What are we actually dealing with? And this is a study that has been done among patients who suffer from urinary tract infections. And as you can see here in the all countries line, the blue one is the one according to the definition, 3 times per year. This is only a bit more than 20%, and that means that all those nearly 80% of patients have much more episodes. And you can see here that in the group of more than 10 episodes per year, it's 30%. So 1/3 of the patients have more than 10 episodes of cystitis per year. And in the slides from Gernot before, you could see it's a high burden for the patients. They have to stay at home maybe. They have to take medication. They have to take antibiotics. So it's a big thing, even so it's only a cystitis. For the diagnostics, I would briefly like to repeat something Gernot said before, but it's of great importance. So a cystitis or urinary tract infection is a syndrome. That means it's a combination of symptoms like frequency, dysuria, pain, and bacteria in the urine. And only when both things are present, then it's actually a urinary tract infection. If you only have the symptoms like urgency, frequency, you should also consider, for example, overactive bladder. If there's only bacteria in the urine, it could be a colonization, and Gernot already mentioned that this does not necessarily need to be treated with antibiotics, causing more and more resistance. So other things about the diagnostic of recurrent urinary tract infections, usually there is no further diagnostic required in uncomplicated young patients. So let's jump into the prophylactic measures. It's stepwise, as Gernot already mentioned. So we're starting with avoidance of risk factors and behavioral modifications. The next thing are the non-antimicrobials, and then followed by the antimicrobials. Of course, I'm not going to talk about the antimicrobials a lot. We all know that. And our goal is to find non-antimicrobial measures. So there has been a trial showing that the additional intake of 1.5 liters of water or drinks, whatever, reduces cystitis episodes and the antibiotic usage. That has been published quite recently. And in the dark blue group, you can see that in the water group, the UTI episodes are lower than in the non-water or control group. However, on the behavioral measures, there's not much scientific evidence. Now we are coming to the non-antimicrobials, and I would like to start with the hormonal replacement here. This is supposed to act by building up the vaginal flora, but also the urethral flora. And from the current point of view, the use is recommended in postmenopausal women. Estrogens are superior to placebo, but inferior to antimicrobials. The vaginal admission has no systematic side effects, but oral admission is not recommended to prevent the urinary tract infections. That has a high level of evidence and a strong rating. Then the immunoprophylaxis. So there is a whole bunch of immune cells in the bladder during a UTI, and this is the background why those vaccinations or immunostimulants were invented. From the evidence, we can summarize that they are recommended to prevent urinary tract infections in all age groups, and it's superior to placebo. There are a bunch of substances on the market at the moment, and there's a high level of evidence. The next are the probiotics. Probiotics are supposed to act by different ways, for example, by inhibiting the uptake by the receptors of the E. coli, by decreasing the pH, by disturbing the biofilm, or by certain cytokines who are released or inhibited as well. From the evidence, it is recommended to use local or oral strains of proven efficacy. Those are the strains that have been shown to be acting against recurrent urinary tract infections when you prescribe those, you should keep in mind to take a look what is actually in those. Usually it's a mixture of lactobacilli, and it's probably worth taking a look which are in there. There is, however, a minimal to low quality of data, which is, for example, because strains of no efficacy have been used, or there are various ways of application, doses, so the data is very heterogeneous. So the level of evidence is good. There have been many, many trials. However, the strength rating is weak. I would also like to talk about cranberry. The recommendation for that is changing more or less every year. It is acting by also inhibiting the E. coli, the pili, and then they cannot be taken up by the urothelium, and by lowering the pH probably as well. They are advised to be used, sorry, but patients should be informed about the low quality of evidence. Also because there's heterogeneous data on the way of application, the doses in each product is different. That's why the data is very heterogeneous. It can be mentioned that the benefit to harm ratio is favorable, so there is not much harm and potentially it's useful. It's a high level of evidence, but the strength rating is quite low. Dimanosis, also acting by inhibiting the uptake, by blocking the receptors. The evidence says that you can use dimanosis, but the patients also need to be informed that the level of evidence is not super good and that further studies are needed to be done to really recommend it. As I said, there's a low quality of the evidence. Then in the last year, methenamine has been added, primarily based on this study comparing methenamine to antibiotics and showing that they are non-inferior to antibiotics. And therefore, the recommendation currently is that you can use them to reduce recurrent UTIs. And last but not least is the endovesical instillations. This is usually with chondroitin sulfate or hyaluronic acids, and it's meant to build up the glycosaminoglycan layer of the bladder. These are the urothelial cells, and this is the mucus, and the mucus is supposed to protect the bladder from substances in the urine, but also from bacteria. Initially, it has been tested for example, overactive bladder or interstitial cystitis, and there it could be shown that the urinary frequency, urgency decreases, and the pelvic pain is reduced as well, and then it was also tested for urinary tract infections. And there you could see that the number of infections per time compared to placebo here is much lower, significantly lower, and also the probability of the absence of recurrence is much higher. From our clinical point of view, we are also testing it in a trial. We also see as an add-on to the reduction of the episodes that, as in overactive bladder, the urgency is much lower and the pelvic pain gets better. With that, sorry. And the recommendation, therefore, currently is that you can use those endovesical instillations with, for example, hyaluronic acid or chondroitin sulfate to prevent UTIs, but you have to keep in mind that it's recommended when the less invasive preventives have not been successful, because, of course, it's an installation in the bladder. It reduces the number of UTI episodes and also prolongs the time to the next episode of a UTI. Those are the summarized recommendations from the guideline panel. And with this, I would like to thank you and hand over to the real clinical perspective to Ria. Thanks a lot.
Good day, everybody. And I'm glad and happy to be here and see a lot of people. That makes me happy. And I'm honored to be invited to speak about a big, underestimated, and not a sexy problem, and the role we can play as nurses. This is a big problem for both patients, caregiver, as well as being a problem for us to solve as well as possible. It causes a huge loss of quality of life for our patients, and as Dr. Bonkert already said, it costs lots of money. These are my disclosures. What's special in the Netherlands? I'm a continence consultancy nurse, and I work in a home care in the Netherlands. And I also work in a specialized clinic for bladder problems. Special in the Netherlands, we have home care, and we keep elderly people as long as possible home. We promote in every way to be self-supported for everyone. We teach a lot of self-catheterization and self-installation. The challenge is that in the Netherlands, there's no reimbursement for bladder rinsing. In the field of home care, I have set up a specialized urologic team. We can give nearly all the urologic care at home. So the hospitals have more space to do what really belongs in the hospital. So in both worlds, I see many urinary tract infections, but I see also many solutions. You do not find home care in all countries, and you therefore have to try find solutions in your outpatient clinic. As a home care nurse, I see a patient in his or her own surrounding. This is of a great benefit, because I can immediately see what might be helpful in this situation. These are mainly elderly and more vulnerable people, as you see here on the page. So when they have a urinary tract infection, this can immediately cause multiple problems. For example, delirium, falling, and this often happens even before you know what's going on. They fall or are confused. Later, you will discover they have a urinary tract infection, or the other way around. They first fall, etc., and then they develop an urinary tract infection. Prevention, as first mentioned, is the best solution. But our challenge is how to prevent this. Cooperation is the key word. With the doctors, the caregivers, the neighbors, everyone in patient surroundings. Know the guidelines and share these. Work in a multidisciplinary way. Get to know your patient, what will work for them and what will not. Involve other specialists. Everyone has his own specific viewpoint and see things differently. Be creative, open, proactive, and think outside the box. As urologic nurses, we all know the things to do or how to inform our patients. Prevention, drink enough water, follow a good diet, hygiene, solve incontinence problem as best as possible. You need good catheter management. This morning, just heard. And we know that keep moving helps to prevent us from falling. When you are incontinent, you have more chance of falling and developing a urinary tract infection. You need to eat well. But what if? What if someone has dementia? What if someone is depressed and lives alone, etc., etc.? What if someone is a care refuser? Bad mobility, lack of intelligence. You can imagine that when someone is alone with dementia, you have a problem. How can we solve this? They forgot to drink, they may not longer feel thirst stimulus, and after, no hunger stimulus either. For example, when our nurses in the morning help their patients, you make a pot of tea for them and place cups in front of them. Then the patient will remember you have to drink. Make notes for them. When there are mental problems, you need all your creative skills. These problems can be different in every situation. Know what's acceptable to your patients and his level of compliance. And accept that things don't always go according to the guidelines. Try to take care of your patients the best way possible, as if it were your own parents. By playing a role in these patients' network, you can prevent a lot of damage. Give the right information to the client and his caregiver. The situation will improve. Well, all these things have Dr. Bouts just explained, and I will put my experience about the installation of the gag therapy to prevent recurrent uterine tract infections. We train a lot on self-installation. How can we do that? And be aware that that they can call you. Gag therapy is recommended by the guidelines, as we just saw. And if the bladder is inside healthy and clean, we will prevent urinary tract infections. In my daily practice, I learn a lot of people self-installation. But how do we do that? Issues on catheter management in recurrent urinary tract infections. We first did it only with a catheter, but we all know the risk of using a catheter. We try to solve urinary tract infections, but you can get this simply by using a catheter. Sometimes that's not avoidable. There's a better way to deal with, and I've done research into the alternative way. The EL adapter. This can prevent even more urinary tract infections than when using a catheter. It's not an invasive way to rinse the urethra and bladder, and I show you the results of our research. These are the reasons why people tried the EL adapter: because of urethral pain, the fear of the catheter, easy to use, and anticipates on fewer infections, and sometimes others. The patient's feedback: 82% of all patients in the group of 50 and older want to continue using the adapter. In the young group, a large but smaller percentage also wants to continue. They have less pain, it's easier, you can do it at home, we can teach them, and there are other reasons. A learning curve, you need a learning curve to do this. When you see this for the first time, when you see someone doing this for the first time, it seems very easy, but you need to learn by trial and error, and give yourself and the patients time to learn. Before you start the treatment, there can be a lot of pain, and there's no relaxation, too much tension. Then wait a little and try again. Perhaps pelvic floor therapy might help. In the Netherlands, I'm training nurses in the clinic, and they admit that when you practice more, your skills will be improved. Conclusion: there's no additional infections in the test group. Mostly it's pain-free, so simultaneous with treatment of both bladder and urethra. It's more effective, and we have quicker results for bladder pain and urethritis. We can treat both men and women, and 75% of the patients continued with the device, also self-application. Practice is necessary. And now the tips for using the adapter. To use it successful, make sure the bladder is as good as empty. You can imagine that the rinse won't work so well with a lot of urine in your bladder. Lay on your back, your feet together, like a butterfly. Tilt your pelvis, the relaxations of the pelvis. And when you don't see the urethra, let them press a little, and you see the urethra. Use half doses by extreme pain or elderly people. And sometimes you can use the adapter just only for urethritis. So you need just a little bit of the rinse. That saves money, because I told you we have no reimbursement in Holland. Add lidocaine to the bladder when there's a lot of pain. Then it's easier to keep it in the bladder. And don't push too hard. Then you'll have pain, but also not too soft, because otherwise it's leaking. My home take message are: the role of the nurse is fundamental in the management of urinary tract infections patients. There's a cooperation between physicians, nurses, and a network of the clients is mandatory. Limit the abuse and use of antibiotics, as the other one. Both also speak of. Try alternative strategies when possible. Gag therapy is effective in prevention of recurrent urinary tract infections, and the EL adapter is an effective alternative way. It takes time to learn. I want to thank you for listening, and when you want to see or try this adapter, then you'll be more than welcome in our stand C53 in the exhibition space. I will be there to explain and show you all the benefits of the adapter, and perhaps something you also can use in your own practice.
Hello. We would shortly like to show you this video, which is on the
A urinary tract
EAU
infection,
patient guidelines.
or UTI, is an infection in any part of your...
It's, you can see it via YouTube or over the EAU guidelines for the patients. It's a new video on urinary tract infections, which is very useful to show it to the patients, to explain them their disease, potential treatments or preventive measures. You can easily find it online. And now we would like to open the roundtable for discussion. Please ask questions.
Yeah, now it's a time for roundtable discussion, and we are looking forward to receive questions, because what you have now heard, you had heard a little bit from me, then you have heard from Katrin, guideline perspective. But what are guidelines? Guidelines are no laws. Guidelines should be considered as guardrails. You should not cross over too much. But now, real-life practice. What are you doing, for example, if you have a patient with a recurrent UTI, with a problem? What is your approach? How are you dealing, for example, with it? I might ask you, who is given, for example, antimicrobial prophylaxis? Yeah, hands up. Yeah. The good thing with antimicrobial prophylaxis, I have to admit, sir, what do you think? What is a good thing with antimicrobial prophylaxis?
Especially, I like to use topical estrogens.
Yeah. It's a good idea, but I just would like to stay from a practical point of view with the antibiotics. The antibiotics are working. And you know, we have always to consider, you have now a patient coming into your office suffering. Okay, we have made a proper diagnosis of recurrent UTI, and we need to help now the patient. Then we know that antimicrobial prophylaxis is working. Therefore, I would say it's not forbidden. And Katrin, I have a question for you now.
Yes.
If we consider antimicrobial prophylaxis, should we give it 3 months, 6 months, 9 or 12 months, or any idea or any comment?
I've never given it for 12 months, I must say, 3 or 6 most of the time. But I must say, when it's over, I made the experience that they come again, the infections. Once the prophylaxis is over, they reoccur.
Yeah. And therefore would be my advice, for example, so I can just say it from colleague to colleagues, that sometimes I start with an antimicrobial prophylaxis. I give it normally for 3 months. Then it's a question, what antibiotic could you give for antimicrobial prophylaxis? And Ria, have you any idea? I know you're a nurse, but you're having an idea what drugs you can give for antimicrobial prophylaxis? Which drugs?
Nitrofurantoïne?
Yeah, that's a good idea. So at least we can give for the prophylaxis the same drugs we are giving for the acute treatment. So we have the nitrofurantoin, and then we have another drug called Mrs. Bausch.
The Cotrim.
Yeah, Cotrim is not bad. And another one?
Fosfomycin?
Phosphomycin. So these are the 3 drugs we can easily give. I see personally one advantage for the phosphomycin that you can give it once a week. There are studies that are given it once every 2 weeks or even every 4 weeks. So this is at least working. And my recommendation would be, if you start with an antibiotic, then you should start as well with another mean. And then it's a question. We have heard so many options. And now I would like to ask you, who is, for example, giving Dimanose? Okay. Then we have cranberry products, at least 2 or 3. Okay. But what, and now I would like to ask you, what would be your recommendation based on your personal experience? What should be number 1, or what is your experience with what should we start? Any ideas?
Can I say?
Yeah.
I guess it totally depends on the patients. You should always try to find out what did they take before. Most of them already tried, for example, Dimanoses or cranberries, because you can usually buy it in a pharmacy or even in a supermarket. And I would like to add that patient history is also always super useful to find a good measure, because when you really take your time for those patients, you sometimes find out that it's only related to sexual interactions, for example, or to reducing the amount of drinking. So do a good patient history, I would recommend as a first step.
Yeah. Thank you very much, Katrin, and thank you very much to the 2 gentlemen already that you are getting up. So we would like to start with number 11 first, sir, please.
Hi, good afternoon. My name is Ramon, and I'm from Valencia in Spain. And I'd like to the audience, if your patients even ask you for food or diet modifications, what do you offer to them? If I know there is not much evidence, but they always ask.
Yeah.
Thank you.
So my comment to this topic would be that, for example, we have a special risk group for recurrent UTIs. This is patients with diabetes. Diabetes should be well controlled. And we have to look a little bit about the amount of sugar which is treated with the urine, because the sugar is one of the most ingredients bacteria like, so glucose. So if you have, for example, patients with a diabetes and they're using drugs where the sugar is excreted by the urine, perhaps you change, or you have to change it a little bit. Of course, we can state, and even if you have no studies, that, for example, fast food is not a good option in general. So we would recommend healthy food, and of course, where we have evidence is the drinking behavior. So you should at least increase your amount of fluid, what you drink, to 1.5 liter or even a little bit more.
Yeah. And take good care of the bowel management.
Yeah, absolutely. Katrin?
No, I totally agree.
Okay,
Nothing to add.
thanks.
Hi, Dick Jensen, Netherlands, Radboud, Nijmegen. I get a lot of patients with recurrent urinary tract infections that are already on prophylactic nitrofurantoin. Most of the patients are on nitrofurantoin in the Netherlands. And then they get the advice when they get a urinary tract infection, like a breakthrough infection, that they get the advice to increase their medication to a more therapeutic dose. What's your opinion on that? Because I always a bit troublesome with that approach. What are you as a guideline?
So if we are going for antimicrobial prophylaxis and you have a breakthrough infection, then I always taking a culture just to seeing whether it's another bacteria, it's resistant or not. So personally, then I would switch to the antibiotic, which is helpful in this setting.
And if it's a patient with severe symptoms and you cannot wait?
Yeah, I would immediately switch. I would treat the episode like an acute episode. I just would take a culture and I would then treat. And if you have, excuse me, if you have no antibiogram and you would like to start an empiric therapy, then I would, for example, switch from nitrofurantoin to fosfomycin. I would just stay with the first line recommendations.
Mm-hmm. Yeah. Definitely, yeah.
Agree.
I noticed that you have here Ialuril orally. It's the same thing that we also use.
Ialuril oral, you ask. How useful is it?
Yeah, this is a good question. So there is a product on the market, and it's marketed a little bit for the patient with pelvic pain syndrome, etc. I am not so keen with the data nowadays, but you know this is a very special group, and we can see what we are discussing. We have many means, and sometimes there are things happening between heaven and earth we completely do not understand. And I think at least we should not harm our patients. And so if we see an option, perhaps it's helpful, but based on hard data, I cannot say that the oral intake of these drugs are currently helpful in the prophylaxis of recurrent infections.
Yeah, you can help the patient with it if everything's done and they have a perspective then. And well, sometimes it helps and then you have done the right thing.
Sir, please.
Hi, Massimo Lazzari, Italy Milan, urologist. Moving on, non-antimicrobial prophylaxis. When you suggest intravesical installations, have you any advice about how many installations, for how long you suggest to take an installation or to take antibiotic treatment? What is your practical advice for your patients or for the audience? Because in literature we know that there is no complete accord about the number, the timing, and when you start the intravesical installation. Thank you very much.
So we do 7 installations. The first 4 with 1 week apart, then then two weeks apart, and then 1 month apart. But I fully agree that in some patients we sometimes add sporadically, like after a month or 6 weeks, again and again, because they they benefit from the pain release, for example. Yeah.
Is there scientific evidence behind this approach?
This is the recommended one, and this is the schedule how the RCT was done.
We do it mostly in talk with the patient. So when the patient has comfort with it and it's better and he's improving, then we make the time between the rinses less. But if it's increasing, then we do more rinses. But it's you work very with the patient together.
And what is going ahead, your idea or your advice about imagining a induction phase for the treatment with installations and then a maintenance phase with the installation? So maybe for bladder cancer, you have, for non-muscle invasive bladder cancer, you have a treatment, a phase of induction and then of maintenance. Yeah. Could you imagine something like that for intravesical installation in recurrent urinary tract infections?
This is kind of what I was trying to say, that it's starting with an intense phase of closer installations, and then you increase the amount of time, and then it's always, it's a disease where you're in really close contact with the patient and really focus on their individual needs.
Yeah.
And I think that is basically what the schedules
And
should.
it's still a little bit a new approach, and so it needs time. For example, if you consider BCG, most probably you know BCG. It's given induction 6 times. Do you know why it's given 6 times? Yeah, because it was produced in a package with 6 ampules in the 70s, and so we thought it 6 times would be good, but there's no scientific basis behind it. It's the beginning, so it's just under development. So more questions. Very good.
Hello.
Sorry, I do not know who was first. It's ladies first.
Okay, yes.
Yeah,
please.
okay, sorry. Yeah.
My name is Janneke van Uhm from Leiden University Hospital in the Netherlands. Thank you for a nice overview. I'm really curious about the role of aminoglycoside use in installation, because in the antibiotic resistance, I think it's a good alternative. How do you think as a committee about that?
Yeah, this is a good idea, and I know already a few data about the installation of aminoglycosides, but it's, again, it's an antibiotic. It should be installed. It must be installed perhaps by the patient, so patients should be trained. So we are looking forward to receive some good data about it, but as far as I've heard, this is an approach, at least as a last line option, that is working in quite a lot of patients. So I think this will become an option.
Really true.
Yeah.
Yeah, and it's good to know that it's just for prophylactic.
Yeah.
It's not as a treatment.
Yeah,
Some
yeah. Yeah.
doctors use it as a
Yeah,
treatment.
yeah,
but
yeah.
yeah.
Thanks. Sorry, sir.
Yeah, thank you. Asif Raza, urologist, London. In terms of vaccine, UTI vaccine, what do you think the role is for vaccination? And although there's evidence that vaccines may give up to a year or 2 years of efficacy, I can't see any evidence of repeat dosing for vaccine. Is there any evidence out there for repeat dosage of vaccine?
Yeah, we have discussed it today in our poster session, so there's definitely a need in a certain amount of patients that need repetition of the vaccination. Yeah.
Yeah. No. Go ahead.
Yeah, no, so it seems that we need to have a booster. Yeah. So 3 minutes to go. Another question? Thank
May
you.
I have another question?
Yeah.
Yes. It would be very interesting to know if you have some tools to predict the success rate or the failure of intravesical installations. I mean, we know that in some cases it's a wonderful solution. After less minimally invasive doesn't work.
You mean the question in the sense, who is the ideal patient for installation?
Can you stratify patients in potential responders or non-potential responders? I mean, for instance, to an investigation of microbiota. We heard that in the suggestion on non-antimicrobial prophylaxis, you use probiotics. We can imagine also postbiotic is a new frontier, or the investigation of microbiota to explain the success or failure after intravesical installation with glycosaminoglycans.
I would suggest let's ask the nurse from the front. Do you have any patients where you consider that installation, or which are the perfect patient from your point of view for installation?
When you have a bladder with denudatie, when it's really infected, and you see it when you do a scopy, you see the bladder is very infected, then we treat with antibiotics and we rinse, and you see improvement very soon, as the patient says. And later we do, after 3 or 4 months, we do another scopy. You see really a much better bladder inside.
Okay. Katrin, and what is your opinion, because you are running a study? Do you have some answers for our colleague who is the best patient for inhalation therapy?
Outcome-wise, I cannot tell, but I would say it needs to be feasible. So it has to be a patient that can keep the liquid inside the bladder for a while and who's compliant. And from the outcome, there's no predictive measure. I think there needs to be research done on the importance of the gut layer, the mucus. I know that it's important for the microbiota, as you said. And it's also important in phage therapy. I guess we don't know much about the mucus, and we need to learn more about it. Definitely.
Okay, our time is over, but the last question, please, sir.
Thank you. I'm Manas de Barma from Mid Yorkshire Hospitals in Wakefield, UK. I was going to first thank you for running such a beautiful session, very informative. I was waiting to hear any mention about methenamine hippurate, which seems to be in our local hospital guidelines from our microbiology department. What's the panel's opinion on?
Yeah, it's included in our new version. So it's a recommendation as a mean to prevent urinary tract infection. We are referring to the so-called ALTAR trial, and which has shown no inferiority against an antibiotic. So it's a recommendation we can give, and we have given now in the current guidelines.
Thank you.
Thanks. So all in all, I would like to thank you. I would like to thank you for your patience, for your activity, for the discussion, and the two ladies for being here with me today. And I wish you a nice Congress and a good day. Thank you very much for being here. And finally, I would like to thank IPSA for the company for support and that we can realize this interesting study and session. Thank you very much.
Thanks a lot.